The shoulder exam, important thing is again inspection. So we are going to want to look at the shoulder to look to see if there's any asymmetry or most commonly atrophy of the muscles. To do this, we actually ask the athlete to take their shirt off. They take their shirt off. And then we can look specifically at the shoulder. We're going to look at the clavicle, acromion, but spine of the scapula. And in between here, we see the supraspinatus fossa, infraspinatus fossa, and the deltoid curve. If they have a sharp angle off the acromion, that could be a sign of a dislocated shoulder or very severely atrophied deltoid. If they have atrophy over the supraspinatus fossa or infraspinatus fossa, that could be a sign of a significant, long-lasting problem of the cuff muscles or nerves going to the cuff muscles. After we do inspection, we're going to do range of motion. There's three range of motion that we're going to check. One is elevation. So in this plane of elevation, we're going to have them lift up over their head, all the way up. Then we put their elbows at their side, and we're going to do external rotation, which is basically the motion that infraspinatus and teres minor does. And then last but not least, we're going to have them stand up and show us their internal rotation, which is oftentimes higher one side than the other, dominant side versus non-dominant side, maybe about 2 centimeters. And this is a marker of internal rotation. You can sometimes measure this based on the height along the spine. If it's about T4 here, it's at the level of the mid-scapula. If it's below it, like T7, T8. Okay, sit on back down. The rest of the exam will continue with strength testing, kind of similar. So arms in front of you, just a little bit in front. We're going to go ahead and do strength testing against resistance. This is for elevation. And strength testing against resistance for external rotation, push out. And then strength testing for internal rotation against resistance. That's enough for strength testing. Next step we're going to do to see if there's any pathologies in the shoulder will be a neurovascular exam. And this exam is accomplished by checking distal pulses, the radius and ulna, as well as checking the ulnar nerve by strength. Push your fingers out wide and resist squeezing them together. So we're measuring the adductor digiti minimi this way, as well as squeezing the hands together on their thighs, squeeze it on their thighs. This is the median nerve. If they have a fracture, oftentimes fractures are mid-clavicular fractures, and you can actually palpate that. Sometimes palpate the step-off or palpate pain. And of course, when they have AC joint injuries, acromioclavicular joint injuries, you'll see a step-off, and you'll have sometimes pain at this junction between the clavicle and the acromion, or in the conoid and trapezoid ligaments that hold the clavicle in place between the coracoid and the clavicle. If they have a supraspinatus injury or infraspinatus injury, oftentimes injury may occur right at the greater tubercle, and it'll hurt when we palpate there. It may also hurt there if they have calcific tendinitis. So to do the adductor drawer test, we basically stabilize the clavicle and the spine and scapula, stabilize the humerus, and gentle force, no more than 10 pounds, usually like 3 or 4 pounds, push the humeral head off of the glenoid. It's a golf ball on a tee, so it can easily come off. If it moves more than 25% or causes some feelings of apprehension amongst the athlete, it's probably a positive. You can do a similar test called a posterior drawer. Last but not least, for instability, is we'll check if the humeral head subluxes down away from the acromion. We ask the athlete to rest and relax their muscles, and then we gently pull down the humerus by grabbing the elbow and the radius and gently tug the humerus, looking for what we call a sulcus sign. If they have instability due to internal impingement and multidirectional instability, oftentimes you'll see a sulcus develop between the deltoid and the acromion, and this is a sign of inferior instability. Okay, so for the labrum testing and biceps tendon testing, there's some overlap. We can start with the biceps tendon, and one of the ways we check for biceps tendon is we'll elevate the arm in flexion, plane of flexion, and this is flexion, this is abduction, and this is extension. So this is plane of flexion. We'll elevate the arm in plane of flexion and fully supinate. When we fully supinate, we rotate the biceps and tighten it. Now we resist against resistance. So if it causes pain up here, that's a positive test. We call this a Speed's test. A similar biceps and labral test is called Jurgensen's, because the biceps has two heads, but one distal attachment at the radius. And because of that distal attachment, the biceps is the strongest supinator in our body, so it supinates the arm. So we're going to have the patient resist supination and flexion at the same time. So I'm going to hold against supination, they're going to supinate and flex, and if that causes pain, that is a positive test. So can you do that? Yeah, so that would be a Jurgensen's sign. Now, further labral tests can be divided into the type of problem that can cause different labral injuries. If you fall, you may have a tear of the labrum, and there's certain tests that are positive. One is called O'Brien's test, or active compression test, another name for O'Brien's test. To do this, we do the similar corkscrewing of the biceps, but this way, pronating it. We adduct about 15-20 degrees, and we resist elevation against resistance. If that causes pain, we do the same by supinating and resist elevation. If that doesn't cause pain, that's considered a positive O'Brien's test or active compression test. This test is especially common with people who fall and injure their labrum this way, but it can be also true with people with the dislocated shoulder will have that. Another good biceps test for the same condition is called crank test. Crank test is abducting the elbow, flexing the elbow to 90 degrees, abducting the shoulder to 160 degrees, and internally and externally rotating the shoulder while you're feeling the glenohumeral joint, almost like McMurray's test. So we don't have to rotate too much, maybe 15-20 degrees, but axial load is important. And if that causes a clunk sensation in there and a pain, that's a positive test. Another test that's similar to this, can you lay down for me? Similar to this is a load and shift test. I'll come over to this side for the camera. And to do load and shift, we will grab the elbow in flexion. We'll load into the humerus and shift. Load and shift. And you feel a clunk, that can be a sign of a labral injury similar to a fall. Now, other types of labral injuries happen. Sometimes we get peel back labral tears in the superior labrum from throwing too hard. And so throwers, like pitchers, can get this. For this test, a couple other tests that are good for this. One is called the biceps load. To do this test, your elbows are flexed at 90 degrees and pronated, your hand, and you resist flexion to your head. This is called biceps load. A similar test called pain provocation is the opposite way, and you push out. If either of those cause pain, that could be consistent with a tear of the labrum, the superior labrum, commonly seen with throwers. Another way of testing for this superior labrum tear is a slide test. We do an anterior slide. We lift up and slide, and you can actually feel the shoulder as you lift up and slide and feel for the clunk, but more often this is a test that'll show pain. Last but not least, the external rotation supination test. If you lay back down, this test is also positive with biceps tendon tears, and so we'll show you this test. It's almost similar to an apprehension test, and this will reproduce pain in patients with a labral tear. Okay, so a common problem that can cause pain in the shoulder is impingement or rotator cuff tears. When you're older than 60, oftentimes rotator cuff tears are very common, maybe the most common cause of shoulder pain, along with arthritis in the shoulder. And impingement is common in all age groups, including young people with internal impingement. One problem with all these tests and the tests we've done so far is there's a lot of overlap. So the tests may be sensitive in certain populations, but not very specific. There's 126 known special tests for the shoulder. We can't do them all, so we use the ones that we think are most useful depending on the clinical history. And knowing that they have false positives. For the example, the test for internal impingement and external impingement in the shoulder, or shoulder impingement, is called Hawkins sign. This was described by Hawkins as plane of flexion and elbow flex 90 degrees and internal rotation. This can elicit pain. It's also been studied outside, and this can elicit pain. Now, no matter what the cause of your shoulder pathology, you could have internal impingement, external impingement, you could have a biceps tendon tear or biceps injury, and even labral injuries. Sometimes the Hawkins signs will be positive, so it's not very specific. With Hawkins, Neer described the test similar, where you just elevate the arm or flex the arm fully, and elevate fully up over your head, and it's a passive compression of the rotator cuff underneath the acromion. To do this better, Neer described it in full pronation. So that's Neer's test. And that's often positive with internal impingement as well as external impingement of the shoulder. Now we have a few more shoulder cuff tests. One is Job's test. Job's test is arms extended, and there's a lateral Job's as well, and you're against resistance, both empty can and open can. And empty can rotates the supraspinatus, anterior fibers away, and you get posterior fibers of supraspinatus and anterior fibers of infraspinatus when you test this way, versus open can, we're testing more just plain supraspinatus. This can be done lateral Jobs like this as well. Now, if someone has a massive rotator cuff tear and you bring their shoulder arm up above their head like this in extension and you let go, it'll often drop it. What they'll do is they'll drop like this. They'll catch their arm, but they'll rotate their body forward and use their thoracic spine muscles to help. So that's called a drop arm test. And another massive rotator cuff sign might be hornblower sign. You tell them to hold their arm like this, but instead they'll drop down. As their supraspinatus and infraspinatus are both torn, they'll drop their arm down. That's called hornblower sign. There's other tests for the subscapularis. Can you stand up for me? And subscapularis test is best done with this test called liftoff. Can you put your hand behind your back and lift up your hand over to here, one hand at a time, over to here. Now push away against me. Push, push, push. That's called liftoff test, or Gerber's liftoff test. This is an important way to do it. If you do it too low, pectoralis muscle can be involved and you get a false negative. If you bring it higher up, you reduce the false negative from pectoralis muscle because you take pectoralis muscle out of the equation. It's mostly subscap. So sit back over here. There's a few other subscap tests. Can you put your hands here and resist me as I push you back? If you can resist me as I push you back, this is a test that helps us figure out if you have subscapularis tear, because if you do, the elbow will fall back. You won't be able to resist. Another one is scarf sign, where you put your elbow here and you resist against me here. That'll also be a positive test with impingement as well as subscapularis.